All right, so on this topic, we're going to be touching on atrial fibrillation and atrial flutter. We're going to talk about these together, and we can really think of atrial fibrillation as worsening flutter. Now, both of these are going to increase the risk of stroke, and it's estimated that the patient who has atrial fibrillation, atrial flutter, is going to have about a 4% more increased risk for stroke than that of patients without. Atrial fibrillation is going to give a slighter increased risk of stroke because of the quivering that happens in the atria. So what happens is the atria quivers, we have stagnant blood, and this blood then begins to have thrombus formation. This thrombus formation leaves, enters the circulatory system, and then we have increased risk of stroke. Now, it really takes about 2 days after symptoms start from atrial fibrillation to produce a thrombus. So we can assume that if symptoms have only been present for less than 2 days, that we do not have a thrombus, and this is going to be important when we talk about management. As far as symptoms, they both present the same way. So symptomatically, it's going to be almost impossible to differentiate the two. Really, they're going to have chest pain, we're going to have shortness of breath, and we're going to have palpitations. Diagnosis is going to be made with the EKG. Now, the EKG, we're going to differentiate the two. Atrial flutter is going to have a sawtooth appearance. It's going to be regular in rate, and let me clarify what I mean by a regular rhythm here. We're going to have a regular atrial rate, but an irregular ventricular rate. So this means the pulse may or may not be regular. Now, for the most part, it's going to have a 2-to-1 conduction, meaning we're going to have an atrial rate of about 300 on average, and we're going to have a ventricular rate of about 150, again, on average. Now, atrial fibrillation is going to be an irregular rhythm. This is going to be how they're going to describe this. So if they present with an irregular rhythm, you have to think atrial fibrillation, and you're not going to see any P waves either on EKG. All right, so that's the EKG there. Now, we're really going to focus most of this lecture here on the management of patients with atrial fibrillation, because this is what's going to be most commonly tested. Now, right off the bat, you have to know anybody that presents who is unstable needs cardioversion, right? Unstable patients require cardioversion. Now, next, let's group the patients into duration of symptoms. Remember, less than 2 days, we have a decreased risk of thrombus formation. So if it's been less than 2 days, we have an option to either cardiovert or rate control with medication. If we're going to rate control with medication, we're going to choose a beta blocker or a calcium channel blocker. Now, the calcium channel blocker has to be a non-dihydropyridine. This is either going to be verapamil or diltiazem. And we can choose any beta blocker in the beta blocker class. Or, like I said, we can cardiovert. Some patients prefer just the cardioversion, and they know the drill. As soon as they have symptoms, they go to the ER and they get cardioverted, no problem. The problem lies if the patient has been present with symptoms for more than 2 days. Right? Over 2 days, now we have an increased risk. Now we might have thrombus formation, and if we cardiovert this patient, we can release this thrombus and then increase the risk of stroke even more. So for the most part, over 2 days, we're going to want to rate control with either a beta blocker or a calcium channel blocker. This is first line here. And if the patient is asymptomatic, we're really looking for a pulse of less than 110 beats per minute. If the patient has symptoms, we're going to rate control to about 85 beats per minute. Now, let's say we have a scenario where the patient comes in and they want to be cardioverted, but they've had symptoms for over 2 days. We have a couple of ways that we can approach this. The first way is to assume that we have a thrombus and simply anticoagulate for 3 to 4 weeks. After 3 to 4 weeks, we can go ahead and cardiovert. Option number 2 is to do an echocardiogram. We do the echocardiogram looking for a thrombus. If we don't see a thrombus, still anticoagulate, but then go ahead and cardiovert. If you do see a thrombus, we have to anticoagulate for 3 to 4 weeks, and then we can go ahead and cardiovert the patient. Now, as far as choosing anticoagulation, Warfarin is not going to be first line. Warfarin is second line. We're really going to be using the oral anticoagulants, dabigatran, apixaban, and rivaroxaban. These are now first line for anticoagulation. If for whatever reason we can't use these medications, then we can go ahead and go with warfarin, warfarin being second line. After we, treat the acute management or the symptoms, then we have to figure out who needs lifelong anticoagulation. Again, lifelong anticoagulation is going to be with the same medications we just discussed, and we're really going to be using Chad's VAS score. Chad's VAS score. C stands for CHF, H stands for hypertension, A stands for age greater than 75. We're going to give these patients 2 points. D stands for diabetes, S stands for stroke or TIA, and the stroke or TIA is also going to get 2 points. Then moving on to VASC, V stands for vascular disease, A stands for age again, except this time it's going to be 65 to 74, and then the last S is going to stand for sex, and this is going to be a female patient. Everything here is going to get a point system like we described, and then we're going to tally up the points, whether it's 1 or 2 points, and if we have 0 to 1 point, we do absolutely nothing. 2 or above, we're going to anticoagulate. Again, we're going to use the dabigatran, apixaban, or we're going to use rivaroxaban. We don't use aspirin anymore. Aspirin has not been found to reduce mortality. There's no point in giving aspirin. It's either do nothing or use the oral anticoagulation agents that we previously described. So we really just have to get the management of atrial fibrillation down. This is what the majority or the biggest portion of the exam, the board exam, is going to be on. And we can really just fit everything in a nice little box, and we know exactly what to do. Remember, less than 2 days, no risk of thrombus formation. Over 2 days, we have risk, rate control. Anybody who's unstable, we're going to cardiovert. If the patient has been symptomatic for over 2 days and they want cardioversion, we have to make sure there's no thrombus. If there is, we need to anticoagulate first. Remember, calcium channel blockers need to be a non-dihydropyridine, verapamil, or diltiazem. And that's it. Atrial flutter, atrial fibrillation.